Hey, glad you stuck around. Thanks for joining us here in the second half hour. When your doctor orders an X-ray, an MRI, a CT scan, the resulting images are going to be studied by a physician who is a radiologist. He or she's going to review the images and then issues a report back to your doctor on what they see going on inside your body. Did you know that that radiologist could be working from his or her basement on the other side of the world? Did you know that some radiologists perform invasive procedures? They're hands-on, doing very important procedures. And did you know that why a doctor would request a particular type of study versus something else? Well, this half hour, our focus is on exactly that. What happens after you have that diagnostic image test and what you need to know about a very highly competitive field of medicine that radiology is. And our guest today is Dr. Saad Ibrahim. He is both a diagnostic and interventional radiologist with Summit Radiology. Thanks for popping in this morning.
Thanks for having me, Lee.
I did some reading about radiologists and the amount of education you guys have to have. It is, I think, extreme, I'll put it that way. You did your residency at Northwestern and then moved on to some preliminary surgery training and then migrated to Yale University. And you have diagnostic radiology specialty there. And then you stayed on for a fellowship afterwards at Yale. How many total years of education have you had?
Yeah, so if you account for 4 years of an undergrad, 4 years of medical school, 1 year of a preliminary year, 4 years of a diagnostic radiology residency, and then a subspecialty year, we're talking a total of 18 years.
Wow. 18 years. So tell me something after all that education. Tell me something about radiology I might not know.
Okay. So I take that back. It's actually 14 years if you take 4 years of med school, 6 years of a residency, 4 years of an undergrad. All right. Well, radiologists are essentially physicians who require subspecialty training and 6 additional years of training after obtaining your medical doctorate. Most people don't know that. To put it into perspective, a radiologist requires 3 additional years of training when you compare him or her to, let's say, a family physician or an internist, and about the same number of years of training as most surgeons do. There's also this misconception that radiologists don't like patient contact, and that is simply not true. As an interventional radiologist, which is what I do, the most gratifying aspect of the work that I do comes from direct patient interactions.
So, but that is somewhat unique, right? There are just people who are diagnostic radiologists who never see a patient.
That is true. I don't know. That is correct. We have Tele-radiology where some diagnostic radiologists could potentially read diagnostic studies from their basement, from their homes or some remote site across the world. Mm-hmm. And so they won't see patients, but the majority of radiologists that work in hospitals will invariably be interacting with patients. For example, a mammographer will invariably be interacting with patients with breast cancer, whether it's biopsies or other imaging tests that are done for them. A lot of musculoskeletal radiologists are now doing invasive procedures as well. And some of them don't do any, but some of them do. So patient interaction is not an uncommon thing for radiologists that work in a hospital.
What drives you crazy when you're watching a TV show, a health-based TV show? There's an X-ray and MRI. It's always plays a key role in there somewhere. What drives you crazy? What did they get wrong?
So not uncommonly, you see a physician who's reviewing an image and it's at a light box. I mean, we haven't done that for 2 decades. Most imaging is actually on a computer, on a big, large monitor, and they rarely show that. They'll show an X-ray, it's sitting at the light box, and he's looking at it. Very difficult to make a good diagnosis from that. With digital technology, we're able to now sit at a workstation and do image interpretation from there. Sometimes in shows, they show the ER physician or the trauma surgeon looking at those images at the light box, making the diagnosis, and that's very uncommon. Yeah. They usually rely on the diagnostic radiologist to do the interpretation and make the findings, and then relay those findings to the ordering physician.
And then how do you do that? Is it written? Is it on the phone? How do you explain to that physician what you see inside the body?
Okay, that's a great question. You do the interpretation, it's done on a computer, and when you're done, you actually sign off on it, and that is electronically transmitted to the referring physician.
So how often is it that that doctor has additional questions and has to get to you?
Well, the way that I deal with this is if I'm reading a study that's positive and there's a critical finding such as a head bleed, a pneumothorax, or the lung has collapsed, or other major trauma within the body, I actually get on the phone and speak to the referring physician and relay those findings in real time as I'm doing that. It's just better for patient care that way.
Yeah, it makes a lot of sense, right? So tell me let's talk a little bit about the various techniques. X-ray been around since the 1800s, for goodness sake.
Yeah.
But MRI and CT and PT a lot sooner than that. So when do you use which one of those technologies?
Yeah, that's another great question. So X-rays in general are very quick to obtain. Usually in the acute setting, if your doctor thinks that you have pneumonia, he'll get a chest X-ray. It's commonly used for broken bones. So they'll get 3 views, and within a few minutes, we'll know whether you have a certain broken bone or not. So it's for quick and rapid diagnosis. It's relatively cheap, and it's quick to interpret.
Okay. And what does an X-ray not do particularly well?
It's a very good question. So ligaments and tendons, although I know that your bone is broken, I can't give you too much information about whether you have another soft tissue injury, like the ligaments and tendons holding those bones together and the surrounding structures.
So MRI, magnetic resonance imaging, that's what MRI stands for. And as the name implies, it's not using an X-ray. How do those things work?
Yeah, so magnetic resonance imaging is an advanced imaging modality. It uses magnets, using physics technique, if you will, not to overwhelm your listenership here. But what it does is it enables, that machine enables the obtaining images of the soft tissues much more better than either CT, X-ray, or other imaging modalities. It'll tell you whether there is edema or soft tissue injury with some fluid around it, and you can actually break it down to, it's this one of your rotator cuffs that's torn if you're looking at the shoulder, or whether you have an ACL or PCL injury, something you cannot do reliably well with either CT or X-rays.
So you're inside the, you go into essentially a tube inside a giant magnet, and that thing is making an incredible racket. What's happening, and what's all that noise going on?
Those are the magnets hitting while it's trying to obtain images of your body. And yes, it is loud, and I've actually had to get my shoulder imaged, and I know what patients go through. They allow you to wear some headphones so you don't have to hear that noise, but it is a longer procedure. We talked about X-rays, a few minutes to obtain. MRI, 30 to 45 minutes sometimes, where you're laying in a tube trying to obtain images. And sometimes those images are between 1,000 and 1,500 for the diagnostic radiologist to interpret.
1,000 images for you to look at?
Correct. That's true. 1,000 images of one body part. It's because different sequences are obtained so that you can problem solve and determine what sequence is best to identify for which tissue you're looking at.
So a big part of your job then is really pattern recognition as you're looking at an image on the screen, right?
That is true. That is true. And the more and more you see of these, and the more and more abnormalities you see, the better you become. And radiologists see a plethora of disease processes, and you just become good at doing that.
So it's like a gardener. You quick glance in the garden, that's a weed, and that's a weed, and that's a weed. You're kind of the same. I never thought of it that way.
Yeah. Similar, but it requires a lot. It's a much more complex thought process.
Yeah,
correct.
14 years of training versus walking into the garden to pull a weed. I get it.
Right.
So if I'm claustrophobic, getting into an MRI is a terrifying experience for people. What can you do about that?
Yeah, that's a great question. I myself was pretty terrified in that machine, and I'm not claustrophobic. What we generally do is we can sedate patients. I, being the radiologist, if I'm at a site and there's a patient who does not want to go in there due to claustrophobia, we could sedate the patient by giving them certain medications to make the process somewhat more seamless for them.
A lot of people, there are independent imaging centers, there are MRI machines in hospitals, there are, lots of different settings there. Does it matter from your standpoint, from the quality of the imaging, where I go? Does that really make a difference?
So where you go really depends on two factors that come to mind. One is how old the machine is, and how where that machine is with respect to current technology. That'd be the first thing. And the second thing would be the technologist performing this study. Those two things can determine the quality of the images obtained. And then that would translate into what is diagnosed. The interpreting physician or the radiologist may have a hard time interpreting a study if a patient is moving throughout a study. So it's really up to the technologist to appropriately position the patient and discuss what it is the study entails.
So if I'm going in for a torn rotator cuff, that's one thing. But if this is a cancer diagnosis, it seems to me like I want to go to the very, very best center. As a patient, how do I know what is the best place for me to go? Because it's my choice, right? I can go wherever I want to go.
That's true. If you were allowed to go anywhere you want to go, the way I would, it'd be very difficult to navigate as a patient. You wouldn't know who has the best technology, where the technicians or, the people putting you on the table are best. What I would recommend is speaking to your physician and asking them if they had a choice of where to go, where would they go, hoping that they could direct you to the best place for imaging. There are just too many options out there. Yeah,
that's tough as a consumer. Choice is a good thing until there's too much choice, right? Then you have to make a tough decision. And we're back with Dr. Saad Ibrahim. He is a radiologist in practice with Summit Radiology here in Fort Wayne. We talked a little bit about his background, all the years of education it takes. And you just said something to me that I thought was kind of interesting, and that is you want to be with a radiologist who has a good amount of experience. So how do I know how much experience the guy on the other end of that computer has looking at my film?
In general, experience counts. It always does. But you rely on board certification. So it's important to know that the radiologist who's interpreting your study is, in fact, board certified. And once you get your report, you can actually look it up on the American Board of Radiology website to see whether or not the interpreting physician is actually board certified. If they are, they have gone through all the rigors of the training and passed all the board certifications and examinations to be board certified and ready to interpret your image.
So you have seen inside thousands of bodies over the years. How much variation is there from person to person?
So in general, we're all essentially the same. Liver's in the right upper quadrant, spleen in the left upper quadrant. We do see variance in anatomy. It's rare, but you do see it. And as a radiologist, because you've looked at thousands and thousands of images, when they occur. Like, for example, you'll have a kidney that's sitting in the pelvis, or the two kidneys on either side of the body that are joined together, which we call a horseshoe kidney. Those are small variants, but more commonly we see vascular variants where the blood supply to the liver may be a variant. It starts off from a different artery and supplies a different part of your body. Those are more common, and as radiologists, we can identify those very quickly, just knowing that these variants occur and exist.
So the same thing, but just in different places.
Correct.
Okay. Let's jump out to the phones real quick. Put on your headsets for me there, will you, Doctor? And let's see what our caller has in mind. Go ahead with your question for Dr. Saad Ibrahim.
Yes, my name is Edith, and I had a CAT scan done in December, and they found something that they needed to have further viewing of, and so in I think it was March, because they had a delay because of all this stuff that's going on with the virus.
COVID, yeah.
But they sent me to have an ultrasound done on my kidneys, and it came back that I had simple cysts, they called it. And, of course, then I went to my doctor to find out what that consists of, and he said that a lot of older people have those and don't even realize it, and which I did not know. And so I was just wondering what the radiologists, how they figure those things out, and what's the difference between a CAT scan and an ultrasound.
Thank you.
That's a very good question. It's a question that commonly comes up, and one of the things I want to tell you is that just like your doctor told you, cysts are very common, and a simple cyst is even more common than that. The way that we look at it is using ultrasound. Sometimes you can put an ultrasound probe in real time over the kidney. You see a cyst, and you're looking for specific characteristics of a cyst. You're looking for a structure with an imperceptible wall. You see increased through transmission, which is basically the ultrasound sound wave actually going through that cyst because there's nothing stopping it. And we know that it's simple fluid. And we can reliably say that this is most likely a cyst and nothing to worry about and does not have malignant potential. On a CT scan, when we see cysts, I use some of the tools I have in front of me, and I can determine by using what we call Hounsfield units how many Hounsfield units the structure has. If it has Hounsfield units that correspond to simple fluid, I essentially put that in the report. I don't usually put that in the impression unless the cyst is a very big size, but many patients have many cysts on both kidneys, and it's not an uncommon finding.
And cysts are typically just encapsulated fluid, right? That's exactly what we're talking about.
That's exactly what it is. It's an encapsulated fluid. You can have it in the liver, you can have it in the kidneys, and so they're not an uncommon finding.
So a CT scan, tell me about those and how they are used. When might you have a CT scan order?
Okay. CT scans are commonly utilized as a very quick scan. You can, once the scan is done, usually 300 to 400 images pop up, and that's because you've got images obtained in 3 different planes of the body. And it's usually obtained in the acute setting. For example, if you've been in a motor vehicle accident, show up to the hospital, it's a good way to determine if there are any solid organ injuries, like your kidney, your liver, your spleen, if any of those have been injured. And it's a very reliable tool to do that. CT scans can be used in other areas as well. You present to the hospital with acute abdominal pain, and your doctor suspects that you have appendicitis. CT scan can reliably show whether the appendix is inflamed or other areas of your body that are inflamed, and give a diagnosis for that. And finally, CT scans are commonly used to determine whether or not you have cancer. So if on ultrasound you find, let's say, for example, a structure that you can't characterize, you may go to CT scanning to try and characterize that abnormality. And
I've understood that as, thinking of it as a loaf of bread. Your body is a loaf of bread, and you're looking at it a slice at a time. Is that correct?
That is true. That's how the images are obtained. They're obtained in slices. So as I scroll through those images, I'm scrolling through slices of your body. And in my head, having gone through so many of them, I know where certain organs are and how they should present themselves as I'm scrolling through your images.
Again, pattern recognition. You have to know what you're looking at. That's amazing.
That is true.
So we did not yet talk about a very interesting part of your career, and that is interventional radiology. Yeah, you can take the headphones off. So instead of just looking at images, you're now actively leading a procedure, and you do a procedure we just talked about a moment ago to treat liver cancer. Describe that for me.
Yeah. As an interventional radiologist, I am able to do minimally invasive image-guided procedures on patients. And one of those procedures is treating liver cancer. So if patients show up to their oncologist and they have disease or a tumor in their liver that's not amenable to surgical resection for curative purposes.
Let me decode that for people. You can't cut it out.
That is true.
Okay, all right.
That's true. So the surgeon is unable to cure you by cutting it out. That patient may be referred to me for liver-directed therapy. And what that means is getting into a blood vessel using minimally invasive techniques and Xray guidance to determine where that tumor is and to treat that tumor. It's not curative, but it does prolong a patient's life pretty significantly.
So you are going up through a vein or an artery and then getting into the liver and doing what?
So you choose an artery, usually in the groin, and you access that artery, thread a catheter, which is a small tube using X-ray guidance, up into an artery that's supplying the liver. You negotiate that catheter into the liver through those blood vessels, again under image guidance, and by injecting dye, you know exactly where the tumor is. Once you've determined which artery is principally supplying this tumor, I can then inject microspheres, small beads, coated with either chemotherapy or radiation, so that they would permanently implant in the tumor-feeding artery. And once it implants there, these are large enough to get caught up into the tumor, and treat that tumor.
We have to leave it there. Time has gotten away from us. That's Dr. Saad Ibrahim from Summit Radiology. Hope you know a little bit more about the work of a radiologist and what it takes to be in that career.